And I'm so excited now to introduce our speaker for today. So Dr. Edin Randall is joining us from Boston Children's Hospital. She is a pediatric psychologist who researches and treats chronic pain in youth and teens. So Dr. Randall focuses on understanding the ping pong between emotions, stress, and chronic pain. And I'm going to stop my screen share now and give you a minute to, or hand it over to you, Dr. Randall, for your presentation. Thank you.
Sounds good. I'm going to upload the presentation and get it into slideshow view. So yeah, I'm going to be talking about primarily the psychological and social aspects of chronic pain, but wanted to give you guys all a really nice overview of what we call the BioPsychoSocial model, which helps, I think, provide some context about where the psychological and the social aspects come into play.
Oh, Dr. Randall, we're seeing your notes.
Oh, you are? That's weird.
Yeah.
I don't have any notes, so there's no secret, but let me see if I can do.
So, and not that it really matters. If there's the swap displays, there you right at the top.
Yeah. Where do you see that?
Oh, it was.
Yeah. Let me do this. Hold on.
No worries. Zoom always messes things up. You never know. Oh, that's perfect. Now we're seeing it in slideshow.
Thank you. Thanks. It's hard to know because I had two screens open that. Okay. Anyway, so I have no conflicts of interest or any disclosures. And just to give you context about who I am and the work that I do, I think that can help put some framework about some of the recommendations I'm making and the information that I'm covering. So I work at the Mayo Family Pediatric Pain Rehabilitation Center at Boston Children's Hospital. And this is something called an interdisciplinary intensive pain treatment program, which means that we have a ton of providers working together to help kids with chronic pain conditions. And those people include doctors, nurse practitioners, physical therapists, occupational therapists, psychologists, social workers, recreational therapists, music therapists. So it's quite the entourage working together we have about 8 kids at a time coming through our program, and they're in our program, our pain treatment program, for somewhere between 4 to 6 weeks. We opened back in 2008 to treat a condition called complex regional pain syndrome. And this is a pain condition that often results after injury. And basically what happens with this condition is there's an injury to the limb, but the tissues and the bones and the muscles heal, but the pain continues. So the pain itself becomes its own disorder. And that's why we opened initially in 2008, but we have since expanded to treat all different types of chronic pain conditions. Some are a lot like FOP in the sense that they have kind of an organic underlying issue. So like juvenile rheumatoid arthritis, ankylosing spondylitis. I think you guys recently had a talk on Ehlers-Danlos syndrome, and things like irritable bowel disease, like Crohn's, colitis. So those are, I would think, conditions that sort of mirror a little bit about like the FOP experience. But we also treat conditions that sometimes have no clear underlying reason why the pain started, or maybe there was an injury like a concussion that resulted in chronic migraines. And so we treat, migraines, abdominal pain, widespread body pain, something called amplified musculoskeletal pain syndrome, and we will soon be extending out to sickle cell disease. So we do treat the gamut of chronic pain conditions. And again, while I'm speaking, feel free, I should open the chat. I'm going to do my best to track it, but it's sometimes hard for me to do both at the same time. So we do have, 15 minutes at the end or more, whatever works for you guys, in terms of answering questions. So when we think about and we conceptualize pain in our clinic, we differentiate between acute pain and chronic pain. And acute pain is what we think about when you have an injury. It's pain that's indicating that there's some harm to the limb or to the body part that hurts. It's adaptive. It keeps us alive. It keeps us, avoiding death, essentially, in the real, like, dramatic biological sense. And immobilization is important, right? You want to make sure that you keep that body part immobilized so that you allow healing to occur. Chronic pain, on the other hand, by definition, is pain that's lasted 3 months or more. And it's pathological in the sense that the chronic pain itself is not really serving any kind of adaptive function, in a sense that the pain is kind of like a false alarm. And in the context of chronic pain, what we know is that when you mobilize or you restrict movement in that particular body part, it actually causes more disability and more problems. And so in our clinic, our focus is functioning before pain reduction. We teach kids how to manage pain and how to cope with pain so that they can do the things that are important to them in their lives. And then ultimately that can help with some pain reduction over time. But we don't have a great ability to target pain itself. Now, how does FOP compare? I want to be really, really clear with this presentation that I am most certainly not an expert on FOP. I am just starting to learn about it. And I realize there's going to be parts of this talk that feel like they may not be relevant for you, but please bring up your questions, put those comments in the chat. I certainly don't want anything that I say to feel invalidating of your experience. So, I do hope that there are parts of this talk that you can certainly take with you and kind of add to your own toolbox. So we can talk at the end about the pain that you struggle with and how you think that, some of the recommendations I make may or may not relate to your experience. But what I do understand about FOP, like I said, is that there is an underlying biological condition that, helps us understand why there is pain. We know that there are certainly acute pain flares. And with that, there's this tricky spot that, that you sit in where the possibility of worsening the condition can be associated with injury and those flares. So when we're thinking about that function before pain reduction, being careful about what that means is important. But what I'm understanding from some of the most recent research is that there is chronic pain kind of underlying some of those acute pain flares. So, in between the flares, there's just overall pain that you're feeling potentially on a daily basis that may or may not be correlated with how progressive the disease is. And that's the pain that I think a lot of what I'm talking about can apply to. But again, we have to manage the difference between acute and chronic pain with a lot of our conditions, like with arthritis, for example, and helping kids learn how to differentiate what's acute and what's chronic. So the biopsychosocial model of pain, I'm not sure how many of you have heard of it, but it really is the gold standard in our pain world, in chronic pain world in particular. It both guides the way we think about pain and it guides the way that we treat it. So the most obvious part of this model is the biological, right? So there's biological reasons why people experience pain. It could be related to disease like FOP, injury, procedures. There's also some understanding there's biological predisposition to pain. So a lot of the kids who come through our program have parents with pain. And we have a pretty good understanding about not really how to cure that part of pain, but we certainly understand how the biological, factors affect pain and also affect your functional status. How disabled are you from your pain? How much are you not doing physical activities, recreational, academic, or employment activities? And how is it affecting your social life and your psychological well-being? So we know that those biological factors directly impact pain and directly impact functional status. The part that's most interesting to me, and I think is the part that we actually have the most control over, are the psychological and the social components of pain. So when we think about the psychological, we often think about how we think about pain. Are we fearful of it? Are we worried about it? How much are we anticipating pain? So kind of like, what is your struggle with pain? Not so much the pain experience itself, but what's your relationship to it? And what kind of coping strategies do you have? Do you tend to avoid pain or do you approach it and try to use strategies to manage it? And then stress obviously is a big component. We know that, our nervous system is responsible for stress. It's responsible for that fight or flight response. And it's also responsible for the experience of pain. So those paths cross. And as Hope described earlier, like they ping pong back and forth. Same thing with the emotional distress. That could be distress related to the pain, or it could be related to other things in your life, right? And so these psychological components are basically never the cause of pain, but can be a factor that turns up the volume of pain or changes your experience of pain and also your functioning within the context of pain. And then the social aspects of pain, and I'm going to dig into the psychological and social a little bit more through this presentation and try to give you guys a couple tools to work with them. But the social parts are kind of like, how does pain affect your relationship to the people around you and your life more generally? So how does the family environment affect your pain experience? How does the community respond? Parents, siblings, and also how do you relate to your social environment? So are you in school? Are you working? Do you have peer relationships? Are you involved in extracurricular activities? Things that kind of expand your self-definition beyond pain. And these things can both directly and indirectly affect pain and your functional ability. So if we don't have a whole lot of control, or, there's some limits to our control of the biological parts of pain, the psychological and social could be good targets of change. So those are the things that I focus on in my program. And also a lot of the other providers. We have a whole slew of providers in our program. So our physical therapists, our occupational therapists, our rec therapists are all thinking about the psychological and social components of pain too. So what I'll do in my treatment with kids is actually go through what are the biopsychosocial components of your pain, right? Because everyone has their own unique experiences with pain. Pain is actually quite subjective. What is a 10 to me is different from Hope's 10, right? So what are the things that affect your pain and where can we make some changes? So with the physical parts of pain, for the kids in our program, a lot of them every one of them is going to have nerve malfunction. Their nervous system is firing. It's kind of in overdrive. We also know that the more that someone's body is weak, so deconditioned, that actually increases pain. And so that's something that often our kids will report. And sometimes there's like scar tissue where an injury may have happened. And then the cognitive, emotional, and the behavioral. So these are actually are the psychological components of pain. And so I'll run through with kids, okay, well, what are the cognitive parts of your pain? Do you tend to attend to pain really carefully? Are you expecting pain in certain circumstances? Are you really focused on it? Do you have a million memories associated with pain? And then the emotional is, both that ping pong. So how does pain make you feel? Every human being, I joke with some of my kids, not really joke, but I use some humor. And I'm like, I'm sure you don't wake up every morning really excited to, face pain again. So pain is, it elicits, and I'll go over this in a little more detail about why biologically we have emotional reactions to pain. But, most people feel sad or anxious or fearful of pain. And that's very normal and very human. And also these emotions can turn the volume of pain up. Like I said earlier, the nervous system, the brain does pain and it also does emotions. And so those paths cross quite a bit. And then what do you do in the context of pain? Are you guarding? Are you avoiding physical activity? Now, again, I understand this is a tricky spot with FOP, but like within the bounds of what you feel comfortable with, are you physically active? Are you doing things that are important to you in your life? And then that sort of bleeds into the social parts of pain. So how much are you engaging in those things that are important to you in life? And how is the world responding to you? Is it productive? Is it helpful? Or is it holding you back potentially? Not intentionally, but is it something that we can help guide the people around you to better support you in a more effective way? So I'm going to dig in a little bit more into the psychological and the social interventions that we use. And obviously, this is just a primer. There's so much that we do in the context of our 6-week treatment, but I'm going to go through some of the basics and just get, kind of the ball rolling. So the very, very first thing that we do in our program is validate and educate. So a lot of kids who come through our program, and I'm not sure what your experiences are, this might be a good topic of chat, but a lot of our kids and families have gone through a pretty rough road before they've come to our program. They didn't know why they had the pain. They were told that the pain was maybe like, we can't figure it out. So are you being bullied at school? Has there been some trauma? Is there a reason, where a lot of medical providers start to if they can't figure out what it is, they tend to say, well, it might be psychological. And so one of the things that we talk a lot about in our program, and I focus a lot on, is validating. Pain is very real. It actually is technically located in the brain. So when people say, pain is in your head, they're actually speaking the truth, not intentionally. But the brain is the organ that processes pain. And it's actually the nervous system itself is the second largest organ in the body. And so why can't the nervous system have issues in the same way, that a heart or a lung or another kind of organ may have issues? And so a fun fact about that too, is that if you were to attach every neuron end to end, you actually could reach the moon. Like, it is huge. So the nervous system is a system that can kind of go awry. Even with an underlying biological condition, the nervous system can get wound up. And we do know that the nervous system does both emotions and it does physical feelings. And so those two things, like I've said, can cross paths. And then we have this concept of central sensitization. So if you have pain for a very long time, what can happen is that your nervous system starts to get wound up and it starts to fire unnecessarily. And why it's called central sensitization is that it's not just the pain that you're feeling in your limbs and your peripheral nervous system. So those are all the nerves that are running from the central nervous system, which is your spinal cord, your brainstem, and your brain. And so sometimes pain can be located in those central parts of your nervous system and have a little bit of a mind of its own. And so what we work on is saying, okay, we know that your psychological factors are not the cause of your pain, but they certainly can be a part of it. And so psychological factors can make pain worse. It can keep pain kind of around. It's obviously a natural consequence of living with pain. And it actually is what can cause some individual differences in terms of pain experiences and also how much pain affects your function. And so it's a really important target for treatment. So I think the very first step is education and validation that pain is real. And just to kind of dig into some of the biological components of pain that sort of cross over with the psychological. So what we see here is that you have a painful location in your body. That triggers a your nervous system within your peripheral nerves, which are the nerves that are in your hand, in your arm, which then send that pain signal to your spinal cord, to your brainstem, and then to your thalamus, which is kind of like the operator in your brain that sends the pain signals to various places in your brain. So the three that are most interesting to me as a psychologist, there's obviously the brain is very much involved in pain. But the first is this right here represents a slice of your brain where a headband might be. So it's literally kind of in the center of your brain. And what we know is that this sensory cortex, it makes a lot of sense. That's the part of your brain that's responsible for physical feeling, the physical sensation of pain. And what's really fascinating is that your body's actually mapped onto your brain. So if I had pain, now the left side of your brain controls the right side of your body. So if I had pain on my right hand, this is where it would be on my brain, where the pain signal would get sent, which is kind of cool to me. And that's not the interesting part to me about chronic pain and the brain. It's the limbic system. So the limbic system contains two important brain parts that are important for the psychological components of pain. One is called the amygdala, and that's the part of your brain that's responsible for emotions, but the big emotions, survival emotions, like fear, excitement, really strong worry, things that keep you alive. And then the limbic system also contains something called the hippocampus, which is responsible for memory. And that's important, right? So if we're thinking about pain, you need to remember things that have caused you pain. It is exactly what keeps us alive. If the last time I went hunting, there was a scary tiger in the left back corner of the field, I need to remember that it was there so that I don't get eaten by the tiger. And then the emotions are important because if you think about the things in your life that you remember the best, they're the ones with the highest amount of emotion. So the emotional part of your brain is what solidifies that memory in your brain. And then the third part of the brain that's important for pain is your frontal lobe, which isn't indicated in this slice of brain because it's in the front. And the frontal lobe, part of what it does is planning and organization. So I need to remember that tiger was in the left back corner of the field and that was where their den was. And I need to then plan tomorrow not to go there. And this is a really awesome and protective, process that our bodies have that are natural. It's really useful for acute pain. But when it comes to chronic pain, it's not very useful because now we have 1,000,000 memories of pain. We're planning our whole life around pain and it's not functional anymore because the pain itself is false alarming, or it's pain that's kind of existing between those flares and it's not indicating an imminent threat. And so we have to teach kids how to override the biology of pain, which is indicating you to feel really bad every day, to have 1,000,000 memories and to avoid everything. And so that's why we need that level of intensive care for our patients who have been very disabled by their pain. I'm not going to show this video. What I can do is give you the link to it, but it's a really cute, quick, I don't know if it's cute, but it's a primer on chronic pain, and it helps kind of dig into some of the biology and why the psychological factors are important in that biopsychosocial model. So I can send that around. So then when we're digging into actually what I do, in the very basic sense, my job is to help kids learn how to cope with pain, help them live with pain, which is really counterintuitive. And probably the worst news that kids hear when they come to our program is that we're not going to be able to directly impact their pain. And then they may not anticipate or experience any pain reduction in the context of our treatment, but we're going to teach them how to do pain better. And the more that they can function with pain, the actual chance that increases that pain will reduce over time. And this is even for kids with arthritis or even with kids with sickle cell, that we can help them have a better experience with their pain. And ultimately that can help with some pain reduction. And with FOP, we're talking specifically when you're not in flare. And then one of the things that I'm going to be really focused on is figuring out for that child, what are the psychological factors that are turning the volume of pain up? And what are the social factors? These may be pre-morbid comorbidities, which means like, not just feeling sad and depressed and anxious and frustrated with your pain, but also, do you have an underlying trauma? Do you have underlying obsessive compulsive disorder, other things or anxiety or depression, or things that could turn the volume of pain up? Because we have to address those. Do you have a temperamental tendency towards being really sensitive or anxious? So how do we manage that? And how do we help kind of modify your coping style so it moves away from avoidance and helps you learn how to approach the things that are important to you in your life? And then what is important to you? What are the extracurricular activities that you want to get involved in? How do you want to get involved in your academic or employment world? And how can we help the family support the kid best? And then just specifically on stress, chronic pain itself is a prolonged stress trigger. It is extremely uncomfortable, and it's something that makes life hard to live. And so obviously we have to address kind of your relationship to your pain, but also, like I said, if there's other stressors in your life, those are important that we help you learn how to manage them, because they are things that can turn up the volume of pain. So digging into the actual interventions that we do. Now, this is like a real quick primer. So obviously we dig in a lot more than what I'm going to be describing here, but there's two different types of psychological treatments that have a lot of evidence base behind them. Cognitive behavioral therapy probably has the most research behind it in terms of supporting interventions around chronic pain. And I imagine that the book that you're reading by Rachel Zofnis covers a lot of the cognitive behavioral interventions. Some of this might be repetition, hopefully. And then acceptance commitment therapy, which is actually kind of one of my favorite modalities. I'm not going to cover it here, but it is a modality that's getting increased evidence base and helps kind of add to the toolbox of cognitive strategies that you can use for managing pain. But both modalities uniquely help address, fear of pain, worries about pain, stress management, relaxation activities, mindfulness activities, basically changing your relationship to pain and to the experiences of pain. So this is just like a broader overview about my approach from a CBT perspective. So obviously I said earlier, I think the first step and the most important one is psychoeducation and validation. So, describing that biopsychosocial model, validating pain experiences. And then the second part, not necessarily in this order, is training and self-regulation. So the nervous system, when you have pain, winds up. It's in that fight or flight mode. And so how do we help kick in what we call the parasympathetic nervous system, which is the part of your nervous system that's responsible for regulation, what we call homeostasis, kind of being in equilibrium. And those are through relaxation and mindfulness techniques. And then the cognitive techniques, like I described, are, how do we help address some of your thoughts, your feelings, and your behaviors around pain? And then the parental involvement. Obviously, I work with kids. It's really important for me and our social worker, who is the person who actually treats parents as people, not just as parents of their child, help them manage their own trauma related to pain and their child's pain, and also their behavioral and cognitive approaches to pain. And just helping the parents support their child in a really effective way. Okay, just wanted to look at the chat to see if there's anything that okay. So cognitive behavioral therapy is, based on obviously cognitive behavioral theory by, we have a couple people who are famous, but Beck is one of them. And basically the focus is on changing what we do and how we think can affect the way that we feel. And CBT targets the stress response. It targets kind of the way that you think about pain. And the goals for me, when it comes to chronic pain, is to help kids improve their function with pain and to reduce their distress related to pain, which can both affect your pain experience. So an example, this is the CBT Triangle, sometimes called the magic triangle. And basically, some of you may have experience with this, but the idea is that thoughts, feelings, and behaviors are all connected. And I'll run through an example that's not pain related with kids. So for example, your best friend or one of your friends doesn't text you back after you text them. And the negative cycle would lead you to believe like, all right, well, my friend hates me, or I'm a loser, or, they are not reaching out to me because I made them mad or something yesterday. That would make me feel bad. It would make me feel sad. It will make me feel depressed, which would then lead me potentially to like cry in my room and withdraw. And so what makes this triangle magic is that the situation's exactly the same. My friend doesn't text me back, but what are the thoughts that I have? How can I reframe my thought? Not in a way that's like kind of BS. Like, I'm so excited my friend didn't text me back, but maybe my friend's busy. It's possible that they are mad at me. And it's also possible that they're really busy or their phone was taken away. What was my feeling? It's not going to be happy, but it will probably be neutral, less anxious, less worried. And what's then my behavior related to those feelings is I might not then withdraw. I might reach out to another friend. And so what makes it magic is the situation's the same, but your relationship to it is different because you've tweaked the way that you think about it. And that possibility that your friend is busy is equally or probably more realistic than the fact that that friend is mad at you. And this is also related to the pain cycle. What we know is that, chronic pain can affect your activity level, which makes you feel bad and can elicit thoughts of feeling like you're a failure or you're never going to be able to do anything or your life's a waste. I'm being dramatic on purpose, which can lead you to then continue to avoid things that are important to you in life, whether it's physical activity or an extracurricular leisure activity. Which if you then don't do that, you have more disability, you become more depressed, more isolated, which then can affect your chronic pain experience. So we have to try to interrupt this cycle in multiple places. One of the things that we do first in our clinic is get kids moving within reason. And we build them up very slowly. And that can help the way that they feel and the way that they think. So just really like specifically to pain, we have a lot of kids who self-limit. So I don't want to go to that party because, the last time I went to a party, I had a really bad pain flare. And so we'll talk about like thought challenging. What's the evidence for that? Are you fortune telling? Are you catastrophizing? Are you thinking in an all or nothing way? Right. And so helping kids recognize like, there's not really an evidence that I'm going to have a pain flare. I'm not a fortune teller, or like, I can still live a full life within reason with pain. Or to validate, I'm nervous about going and I need to go anyways, because it's important to me. So how do we tweak the way that we think so that we can do the things that are important to us? And the same thing with working with parents. How do we tweak, parental in the same way that kids are biologically driven to avoid pain? Because if you leave your cave and you're hurt, you're going to get eaten. It's the same thing with parents. A parent's job is to protect and to nurture and to make sure your child is safe. And so you are instinctually and biologically driven to protect. But what we know with chronic pain, especially for the conditions we treat in our clinic, that the protection to a point can be helpful, but to a point it starts to limit. And so how do you encourage parents within the context of feeling, comfortable and in a gradual way, allow their child to live the life that they want to live with pain? And it's hard work. That's why they're involved in our program very intimately. They attend a lot of sessions in our program each day to start to shift that, biological drive. And then just the behavioral components, how do we address that? And so we use what we call graded exposure, which is gradually exposing kids to their feared activity. So let's say a child struggled with limb pain, had a broken bone, it healed, maybe CRPS, for example, but they really want to run. We would never put a kid on a treadmill for a mile run like their first week. one, biologically that's unsafe. They have a lot of weakness. Their bones are probably pretty brittle because they haven't put weight on them. So it's biologically doesn't make any sense, but psychologically, from my perspective, you are flooding that child with fear. And so how do we come up with a really gradual approach to approach those things that are important to them? So what we will do is create like a fear ladder, which is a stepwise approach controlled by the child, input from the clinician of how they approach that thing that they really were scared of. Distraction is one of our primary interventions. Whenever a kid is in PT or occupational therapy, they're playing games, they're dividing their attention away from pain. Again, with kids who have arthritis or sickle cell, they need to understand like what is pain that is safe to move your head away from, and what is chronic pain, which is not functional, that you can allow to shift to the background. We know that you cannot focus on two things 100%. So if we can get 30% of your focus away from pain, your pain experience is improved. And so we use a lot of distraction techniques, which can be, and I'll show you examples of distraction techniques from a kid. We have a coping list that we create. And then relaxation techniques are really important. A lot of kids in our program will say they've had negative experiences with deep breathing or with visualization, and we encourage them to try it again because we know biologically how important your breath is for controlling your heart and controlling your body being regulated. So this is an example of a coping list that I'll create with kids. There's 4 categories. Distraction, like I said, is one of our main, tools. You can see there's a slew of options for these kids. A lot of them use a lot of fidgets and putty and board games and card games, and they do things to move their head away from pain. Movement and exercise, again, respecting kind of the limitations with FOP, but how do you get your brain and your nervous system into a mode where it knows that it's safe and doing normal activities is safe? And so these are some examples of things that kids use in our program. The home exercise program is the HEP and Keep Moving plan. We have all these plans that we develop with kids to help them in pain flare, manage their pain. And then we have the cognitive aspects, which we've talked a little bit about. We talk a lot about reframing and challenging negative thoughts. We don't ask kids about their pain in our program because it brings their attention to it. We know they're in pain. It's not useful for us to keep asking them a million times to rate their pain. And then relaxation strategies. There's a slew of them here. They're not just all deep breathing and guided imagery. There's things that cuddling up in your favorite blanket, sitting in the sun, right? Like things that just bring your nervous system down and help regulate. And then the science speaks for itself when it comes to relaxation. When kids are telling me that they've had a really negative experience, maybe they've had a panic attack and someone told them to do all their deep breathing and they start to hyperventilate, it's because they're not well practiced at it. And so we have to teach kids how to best relax their body through diaphragmatic breathing, and through what we call biofeedback, which is basically like helping you use your head to affect your biology. And those are things that can help with reducing muscle tension, reducing your heart rate, increasing oxygen, and it can actually increase your feelings that you have control over your pain, which is really powerful. And these can all affect your biology, decreasing kind of your physiological arousal. So relaxation is really important, but it is not the only tool. And I think sometimes when people talk about chronic pain and chronic pain management, this is where they go. And I think it's just one tool in the tool bag. And for some people, it doesn't work that great. So we want to be able to diversify what's in your coping toolbox. Okay, now we're into the social aspect. So just a quick review of what we do in our program. But and this is a very so acceptance commitment therapy concept, is the importance of your values. What is important? First of all, what's important to you, and how has pain impacted your ability to live your life according to what's important to you? What's your life compass? Where do you want your life going? And I don't mean goals. I just mean your values. Do you want to be, being artistic is important to you, or being a good friend, or giving back to your community, right? There's just general things that make you, that extends your self-definition beyond pain. And that's really important. Obviously, pain and disability are part of your life narrative, and it's, part of your thread, but there's so much more that makes all of you, you. And so how do we allow you to do those things that will make you, you? So the more you will live according to your values while respecting your limitations and respecting the impact of pain on your life, the happier you will be. And this can directly actually impact your pain experience and make it easier to deal with. So when we're in our program, we work really closely with schools. And obviously, if a kid has an employer, we encourage them, we sort of train them on how to interact with their employer to get the accommodations they need. So a lot of our kids will get extended time on tests and assignments. They'll get, more time to transition. Obviously, these are things I'm sure a lot of you are familiar with in terms of 504 plans or individualized educational plans. But we don't just throw kids into the fire. We know that they need accommodations and we support them in getting them. And then extracurricular activity involvement. So that's not just structure, that's, also leisure activities. We have a rec therapist that works closely with our kids to help them decide like what's important to them and what do they want to get involved in. And this not only helps expand your self-definition, but it connects you with like-minded peers that share something with you outside of pain and disability. And then the social relationships, a lot of our kids are withdrawing from their friends. And unfortunately, in those teenage years, out of sight, out of mind. So it's not that the kids don't like them. They just aren't thinking about them because they've said no to too many invitations. So helping kids, educate their peers about what they have, within reason and what their comfort level is, and accepting invites, extending invites, helping them reconnect with their peers, because a lot of them have become quite isolated because of pain. And then the family relations. How do you interact with your family members? Are you still doing the things that keep the house running? Are you involved in chores within reason? Are you doing the things that make you feel good as like a daughter or son or, whatever? And then how are the parents, best supported and in effectively helping their child? I do have a few resources. It sounds like you guys have been working through this chronic pain and illness, like workbook for teens. So that one's great, by Rachel Zoffness. Rachel Coakley is a psychologist in our program who wrote a really good book that's more of a for the parents around helping to support your child with chronic pain. So I suggest, I'm not promoting my colleague. It's a good book. And then this book by Mosley is kind of a cool, it's almost like cartoony and interactive around chronic pain. And I use a couple of these pages to help with the education part of my, my work with kids and families. And then finally, questions. So I'm done with my part of the presentation, and I'm going to look at the chat, but open it up to people for questions or, your perspective on this based on FOP and your experiences with FOP.
And I know Sharon just put a big comment into the chat, so I'll give you a minute to read that, Dr. Randall. But I wanted to say first that we asked you to cover a lot of information. Pain psychology is just one branch, one pillar, but there's still so much to it. So I just want to say thank you for, in the amount of time that we had, giving such incredible insight to the depth. And I hope people walk away realizing that the workbook and some of the activities, the CBT activities that we're going to do together in the community chat portion are great things for people to be able to do on their own. But there's obviously a tremendous benefit to going to a psychologist or someone who specializes in this field to work in whether it's an inpatient setting like what you guys offer, or just a outpatient clinic, a regular appointment. So thank you for that.
My pleasure. Actually speaking to this long comment, I'm actually was talking with one of my colleagues who is an adult anesthesiologist who works in adult pain. And this model that we have in pediatrics, this intensive interdisciplinary pain treatment program, is not very available. There's probably like 7 in our country, and internationally, let's say like 9. It's pretty uncommon, hard to get to, hard to learn about. But in the adult world, they just don't have, I think we were trying to figure out what it is. It must be insurance or something kind of like, all these infrastructural issues that don't give, adults the opportunity to engage in a program like this that is biopsychosocial, that addresses all the parts of pain. And I think that's a real problem in adult medicine. We're in the process of writing an op-ed about this because of the problem with this. So I think it's not accessible to a lot of people, certainly socioeconomically, but I do think, for all conditions, this approach can be really helpful. And in fact, we're extending it even to like long COVID symptoms, which is interesting too. But you're right. I think it's sad to me that I think the medical community tends to focus on the biological parts for both treatment and conceptualization. Now, to find a professional, I don't know where you live in a city with me. you could ask your pain treatment program if you're I would start with pain treatment. So if you've not worked or connected with a pain treatment program, you could start there, and they may have some resources for a program that's similar to us. I know in Massachusetts, Spalding Rehab has a program for adults that's takes the biopsychosocial approach. But when I'm working on this op-ed, I'm going to try to collect more information about programs nationally and internationally that take this biopsychosocial approach for adults. I hope I answered your question.
I did have a question for you, and I also wanted to say that you're a child psychologist, so you work specifically with children, teens. But as I was listening to your presentation, so much of what you were saying, even though you refer specifically to children, I think is applicable to adults as well, the theories and the techniques. So anyone watching the recording or listening, I hope you take that to heart, that it can apply to you as well. But I had a question from a mom who has a young son, and she was asking or saying that, it's hard to tell. She feels like he doesn't necessarily communicate when he's in pain. I think that's common. A lot of our kiddos want to be tough, they want to put up that front that everything's okay. But if parents are having a hard time understanding the pain that their child is in, do you have any tips about how you can tell if someone's in pain if they're not telling you specifically?
Yeah, I think, certainly there's what we call, I don't like this term, but we call it like pain behaviors, like, whether there's posturing, grimacing. As a mother of a child with pain, you can probably, we talk about like the sixth sense, like get a sense even when they're not talking, their face gets white, or they lose color, or they're withdrawing a little bit. What I would do is obviously, like, if you could talk with your kid about, it's very impressive that you're able to put on that strong front, but it's really important for me to know when you're struggling more, not to complain, but just so that I can be a support. I could engage in a distraction technique with you. I can encourage you to go, I don't know, for a walk, if that makes sense for you. Like to talk about opening those lines of communication up, not in a complainy way, but so that the family and the community can best support, and just, I also commend them for, you can be strong and still talk about things that you're struggling with.
That's great insight. And yeah, just more in the chat, more expression, I think, of the frustration for adults, especially because of the accessibility to this treatment. So
I'm literally, if I can use some of these quotes in our op-ed, we need to get the message out that I don't know if there's a bias, which is really sad, where, you have kids, they're changeable, they're young, there's a lot of stigma around pain in adults, a lot, especially with all of this talk around the opioid crisis. And, there's certain times when opioids are really important to use. And it's just creating a culture and a dynamic where I think insurance companies they're not funding this type of intervention for adults. And I don't really understand why. I know it took a lot of fighting in our pediatric clinic back in 2008 to get insurance companies to fund what we were doing, but there's a huge research base now developing on the efficacy of this model. And I don't understand. And I think it's something that we need to bring attention to.
And just a plug for our week 5 session. So, Jamin, I'm going to mispronounce his last name, Obadiah, is a researcher who is affiliated with Boston Children's Hospital, and he has been at past family gatherings. He is specifically researching pain and FOP and other rare musculoskeletal diseases. So in a presentation that he is going to do in a couple of weeks, he's going to emphasize really how this biopsychosocial approach is really critical for people with FOP. So it's great to hear that there's already research, in our disease community specifically, that's kind of reinforcing and helping to validate what you're saying. So.
Yeah, and I know Jamin and I are going to be working together to try to write some grants and see what we can do in terms of this intervention. Obviously I'm a kid person, so working with kids, but, thinking about adults, because it really is, again, the adults in so many ways with chronic pain are a group that's not being addressed in the way that they need to be. So yeah, it's a big problem.
Oh, sorry, I didn't mean to cut you off. I was just going to say, if anyone has any other questions, please do feel free to put those in the chat. I think we're seeing lots of comments, which is great. I love this conversation. I want to continue it over into the community chat portion. But if you have questions, maybe one more minute to put those into the chat or unmute and raise your hand. And I just want to say thank you again so much. Oh, there's one that came in about how you can explain the brain handles acute pain versus chronic pain differently. Do you want to take that one, Dr. Randall?
It doesn't. That's the problem. The nervous system doesn't know the difference between acute and chronic pain. And so it's just about how much that cycle is getting repeated. And the other thing with chronic pain is what's happening is that the brain isn't inhibiting the down sort of the sending of pain signal to the body very well. Whereas with acute pain, at some point it ends. Medications are really good at intervening with acute pain. They work with acute pain. And one of the things that's sort of diagnostic for us is when those pain medications aren't working, we're probably dealing with a chronic pain condition at that point, or at least a chronic pain plus acute pain situation. So the brain actually doesn't know the difference. And that's why the pain experience with chronic pain is very similar to that of acute.
Yeah. A really important part to understand for sure. Okay. Well,
Yeah, and
I'm going to pull up.
Feel free to also, any questions, if you don't feel comfortable in the public setting, I'm happy to talk to anyone. If you wanted to set up a time to chat or send me an email with questions. We're also going to have a physical therapist from my clinic talk. I think that will be really cool. She's been working with us forever and is a real expert with chronic pain and in pediatrics, but she can speak to the adult pain part as well in terms of physical therapy.
Yeah, she's in week 4. I'm so sorry. Julie, if you watch this, I'm so sorry I forgot to shout you out.
I don't think she was going to try to make it, but I think she had a meeting that she didn't realize. So
no worries. Well, thank you again so much, Dr. Randall, for joining us today. And if you have questions, yes, please feel free to email me and I'm happy to pass them along or put you in touch. So, and there's one more question that just came in about distractions, finding if you can't find one that works.
Distraction is one of the things actually that works pretty well with everybody. Okay. It's about finding the thing that's engaging your brain the most. So, and there's going to be times when you've got to max out those distractions. Maybe you're doing 2 at the same time, listening to music, playing with the fidget, and playing a video game, right? Like when kids are in pain flare, sometimes we have to amp that up. So I think you're just going to want to maybe look at that list that I send out. I can also send a PDF of this presentation out. That's just an example, but there's tons of things that you can do that if you just try to play around with it, you could probably find something. It's not going to take your pain away, but it's going to help distract and divide your attention away for a portion of it, and also help you continue to do the thing that's important to you while you're distracting yourself away from it. But I get it. It can be hard to find that thing.